All right. A few more seconds. Okay, we'll start in a few seconds. All right. Good evening and welcome to AMDA COVID Grand Rounds, Pearls from your colleagues, and happy hour on the East Coast only though. I'm Sabine von Price-Friedman from the Washington State AMDA chapter, your host today. And this is a series of what will be ongoing peer discussions on COVID-19 in the post-acute and long-term care space. We know that the populations we serve are some of the hardest hit by this virus. We also know our patients have some very specific needs, and we want to make sure that we learn what we can about what serves them best through data or practice. We aim to capture what you and your peers have learned the hard way. We also want to identify and highlight the data that is helpful managing our patients' particular needs. We want to make this an interactive discussion, and I encourage you to use your chat function. Chat is your friend, but it's also a tool for us to ensure that we get the questions that are most specific to your needs. Today, we want to start off the discussion with 3 topics: anticoagulation, hydration, to hydrate or not to hydrate our COVID patients, and then testing, specifically the role of antibody testing. And finally, we hope to touch on how to communicate our directions to our medical staff most effectively. This has been a real challenge for me. I've had some rogue players out there. And here with us today, we're really pleased to have several distinguished post-acute and long-term care leaders who are likely familiar to you and probably don't even need an introduction. We have Dr. Chuck Quasilius, and I've now lost all my intro. So I'm going to have you introduce yourselves. Chuck, give us a little spiel on who you are.
Okay. Currently, I'm the medical director for our BJC Medical Group, part of the Washington University system in St. Louis, Missouri. I still go to nursing homes, but I spend 60% of my time in administrative duties coordinating 11 hospitals and 150 area nursing homes.
Wow.
Still working with the Missouri Quality Improvement Project and rehospitalizations. I'm a past president of AMDA and still involved in public policy.
And you know, you look really different to all of us, and we figured it finally out. Tell us what happened.
Yes, it was a choice of a beard or an N95 mask.
Yeah.
So N95 okay. Trumped.
Okay. All right. Rich, do you want to go next, introducing yourself?
Sure, I'd be glad to. Thanks. So I'm Rich Pfeiffer. I'm Chief Medical Officer at Genesis Healthcare. Genesis operates about 400 skilled nursing facilities in 25 states. I also serve as the leader of Genesis Physician Services, which is our subsidiary provider group of physicians, nurse practitioners, PAs. So it's great to be with you all.
Thank you. And last but not least, Arif.
Hi, Sabine. Hi, everyone. My name is Arif Nazir. I'm Chief Medical Officer, Signature Healthcare. We have about 110 facilities. I'm also in the role of leading our practitioner group, where we have like 70 nurse practitioners. And we're currently providing care to around, I would say, 800 or so COVID patients in our facilities. So some hard lessons learned, as Sabine said there, so we'll be happy to share and very much open to learning tonight. Thank you for the opportunity.
Yeah, and I think that's the situation we're all in, and that's why we're together today. So we want to start with a question to you. So Aaron, can I have poll number 1? So this is pretty intuitive. Aaron is going to show you this poll, and you're just going to click on it, I guess. Oh, I guess this is an education for us too, because we're learning where everyone is. So I think we're done with end of polling, and this is an interesting, response. So we are pretty much all over the place, but probably more people ordering it than not ordering it. And there has been a lot of literature on COVID causing a hypercoagulable state and associated mortality. Much of that, though, is coming from the ICU experience. The question is, should we anticoagulate our patients with active COVID? Who wants to start this discussion off? Chuck, how about you?
Sure, yeah. We always have to individualize medicine. The problem with a question like this, it doesn't tell you how sick the patient is. There's those people with COVID who actually have fairly mild forms that are still fairly active. They don't go through a major COVID or cytokine crisis. They're mobile quickly, and I'd be less likely to anticoagulate them. Somebody's been through a cytokine storm, somebody that's going to be immobile for quite some time, I'm much more likely to anticoagulate them. And of course, you have to take their premorbid bleeding risk into account.
Does everyone, Rich, do you have anything to add to that?
Well, I would. And the story here, and it's the story of the whole pandemic, is that we're making decisions and we're navigating without adequate data or information to guide us. We're not used to that. It's not how we were trained, right? And so we have uncertainty and we have evolving data. So the most important thing is that we're plugged in and we're aware of the data that's coming toward us and we're interpreting it. So when I look at the survey results that you just showed there, I was glad to hear that so many people are sometimes prescribing prophylactic therapy. They're thinking about it. I would ask the other two groups the following questions. See, I'm gonna answer with a question. I'd ask the group that's not using prophylactic therapy, is that because they're not aware that there's a potential hazard here that we're still learning about, or they're evaluating patients and they think their patients have a greater risk and benefit profile? I hope it's the latter. And if we're evaluating our patients and we think the risk of bleeding is higher than on an individual level their potential benefit, then that maybe is a reasonable outcome. The same thing for the group at the bottom that are doing this more routinely. Is that because their patients have a low bleeding risk and they think a high risk of thromboembolic events or what have you? So to me, the key, as Chuck said, is tailoring the decision to the individual patients and being aware of the science as it's emerging.
Speaking of science, there's several follow-up questions, and guys, feel free, audience, feel free to tap away at the chat function if you have any follow-up questions. I have a follow-up question for RF. What's the science? What is the data that we actually know? If anybody else wants to answer that one, I don't want to put you necessarily on the spot, but what do we actually know?
Well, that's from COVID's point of view, I think that's the easiest question you can ask tonight is there's no data in our patient, right? Simple question, I can't be wrong, full marks to me.
I agree with that.
But the data does, but the data does exist from the ICU side, and we're seeing, some of these associations from the hematology side, from chest, and we have seen some of the data coming through. But, that all data, as, Chuck said, have gone for people who have gone through the cytokine storm, which, applies to some of our patients, right? I mean, the ones who are palliative care, who are not going to the hospital. So there definitely is a proportion of our patients where the data does apply. But again, these studies were not done in nursing home patients, so geography wasn't there. But again, the physiology or pathology was there. So we have to be really smart in kind of how we extrapolate that. I would add to what kind of the thought process which Rich shared with us is it's hard to practice in and not in the light not having much data. But I would like to differ a little bit on that. Like actually, geriatricians are very well versed in practicing, particularly the ones who are on PALTC setting. We actually have learned to practice, over the last many decades, practicing medicine, extrapolating and all that. It's getting better. I think researchers are paying more attention to PALTC and whatnot. But I think if anybody does have that discomfort of practicing and not having much data, I think it's us. But again, it does not mean it's not uncomfortable. It is quite uncomfortable. And the last thing I'm going to say is that whenever somebody asks me about this question, like what you should do or not do around anticoagulation, I tell them that there's two things you must do when it comes to anticoagulation, which are very clear. Number one, that you should always think about anticoagulation issues in any time somebody brings up a COVID patient to you. Think about it, right? I mean, your decision should not be made because you just didn't think about it. That's the absolute wrong thing to do. And the other thing which we know about it is what you should not do. You should not put a blanket statement that every patient coming to my facility on a COVID unit who gets COVID diagnosis will get anticoagulation, because I've seen all those kind of approaches being practiced in post-acute LTC, where people want to put this order sets and want to do a deal with it as a blanket statement. And ELTC is one place where you just do not have any luxury of doing any kind of blankets. So,
well, I think very well put. And we have a follow-up question here from Leslie Eber. Hi, Leslie. What is your algorithm to make this decision? And I also have a question, a clarification question. What about, and we had a similar question from the audience prior to our webinar, what about patients who have had their a cytokine storm and have had their ICU visit and have survived and are now with us? So, so if anybody wants to comment on the algorithm or on that particular question that was posed to us prior to the webinar. And then we want to also make sure that everyone knows that AMDA has a new guidance on this posted. So very timely question. So anybody want to take a shot at algorithms, or do we want to just refer to the new guidance? Anybody wrote this guidance? You might want to.
I would say that the new guidance is not coming out till in a week. I just want to correct that, add that, but because I know it's been worked on, but it's coming out pretty soon. But I will look at Chuck, whenever it comes to algorithms and evidence, I think Chuck and Rich probably can take the lead on this one.
If I have a patient coming to me that's been through the cytokine storm and is relatively stable, I just look at them as a very high risk, probably somewhat similar to a hip fracture patient. Yeah. If I'm going to make an analogy, and I'm going to lean towards anticoagulating if they're safe for a short period of time until they're mobile.
Do you have a favorite agent?
Yeah, that was the second question. I'm probably going to use a low dose, low molecular weight heparin.
Yeah, and enoxaparin.
Something that's short acting. I'm not going to use one of the new I think that's too risky, too long acting, too strong.
Mm-hmm. Mm-hmm. Does anybody have anything to add to that?
No, that sounds reasonable, and we're going to learn. It sounds like, what Chuck you're doing, and I'd agree with it, is to look at a patient and say, okay, who am I caring for in my post-acute setting who might fit the mold for hospital level care, right? Even though they're on site, they're being cared for in place, but they might have been in the hospital, and so they're post-cytokine storm, they're at high risk. Let's care for them as though they're at the hospital. We just happen to be using our care setting, and that's how I tend to think about it.
Yeah, I think that's a very good way of thinking.
And the only thing I would add is, like, for a principle to use is that the less you can work you can create for your nursing teams, like the medicine you want to use less often. I think that's a pretty good principle to use that way. I'm not promoting any one medicine. I'm not going to say any medicine at this point, but just think about your nursing teams and infection control principles to try to make sure that nobody has to enter the room to give your medicine 3 times a day. Try to use the 1 time a day medicine if you can. And in terms of duration, where again I've seen the literature based from various associations, at least 3 weeks of treatment since once it was started, I think is a reasonable thing. But I've seen studies where they're showing up to 45 days. But I would say 3 weeks probably would be a reasonable time frame to keep them on it, just for that specific reason. Now, they may have other reasons. Now, remember, other medical problems don't cease to happen when somebody gets a COVID diagnosis. They can still have other reasons to be anticoagulated and so forth. Just keep that all in mind, But from COVID point of view, I think 3 weeks is a reasonable time frame to start.
Would it be okay if I built off of Arif's comment just now? This point about nursing burden, not just the workload on a stretched nursing team and sometimes a staffing crunch, but also the need to enter and exit the room and things like that. That's a very important issue during this pandemic, not to be understated. And so I think that's something we need to consider whenever we entertain treatment, especially about things that are even less evidence-based than anticoagulation, which is what we're talking about now. We probably don't have time tonight to get into all sorts of other hypothetical treatments, vitamin this and supplement that, but you've all heard about those. And whether or not they work or are potentially harmful is one concern, but the that you mentioned just now is so important. Anytime we start throwing things at patients in the hope that it might help, we're increasing nursing burden and exposure, and that's a big deal.
Mm-hmm. Mm-hmm. Well, I think this is also a great segue to our next topic. Erin, could you we'll poll you again and see where you guys are at, and then we'll take it from there. Why don't you go with poll number 2? In the absence of a history of significant CHF in the typical patient, what is your goal for patient hydration status with COVID-19 in the early stages of the disease? Oh, this is a neck on neck here. I think we're done with the polling, and the winner is keep well hydrated, and runner-up is aim for you bulimia. Only a minority of our listeners think we should keep them modestly dry. Now, remember, we are talking early stages of the disease, and we are also not talking significant CHF. So I know from my personal experience that patients, and my N is fairly small, I have to say. I have treated a number, but not that many personally. People become pretty listless when they can become pretty listless. Not all. I mean, I have my 95-year-old who doesn't even know they are sick, but when people get symptomatic, they can become listless, and hydration has seemed to improve that. But then again, I'd like to know your current opinion on hydration, and whether we have any science behind it is always the interesting question around that. Who wants to take a stab at it? Who wrote that question?
Well,
All right, Charles.
I wrote the question because I didn't know.
Okay.
When I wrote the question, part of the intent was if they haven't had a cytokine storm yet, and it's
Okay.
potential, if they're in the nursing home, is there an advantage keeping them dry in anticipation of becoming wet lung and all that sort of problem? Nobody knows. I was more interested to see what the results were than say there's science here. I think this is the hardest subject to address, the least amount of science. Certainly once they get inflamed, you know what to do. But otherwise, in the early
What
stages.
is it that you do, since you know?
I personally aim for more towards euvolemia, not knowing which way things are going to go. Yeah, but I don't want them horribly dry by any means. And
I think, and I mean, to me, that one of the concerns which I have around COVID and the panic it causes and the team burden it leads to is it's 2 things: is isolation our patients having, and then hydration issues, right? I mean, with the kind of environment this pandemic unfortunately has created in our facilities, I think we always kind of were on the verge of being around the volume depletion in our nursing homes, just because staffing issues or dementia issues and all the other reasons people have. So to me, that's my biggest concern. Particularly in my role as chief medical officer. I mean, one thing which kind of worries me is like how well my teams are able to make sure that people are getting their needs met, particularly when their loved ones are not in the room. And again, I'm not faulting out the staff for that. The staff can only do that much. I mean, the staff have to do trainings. They have to doff and don PPE now. They have to listen to 15 webinars every day from the state and from their CMOs now. Like, there's just so much staff has to do. And there is a price we pay. To me, the chaos does get us on the side of dehydration, unfortunately, or volume depletion. So I would really, if anything, would want to make sure that I put in systems in place that people are well hydrated. And one of my colleagues, Steve Buslovich, I'm going to shout out to him. He actually is doing a trial of ice cream. And he says that he's seen a significant benefit. And by the way, who can say no to ice cream? So what a great, simple way of kind of pushing for, some rational stuff in making sure that our patients are on the hydration status.
Is Steve's study powered to detect differences between vanilla and chocolate? I'd ask.
That was my next question.
Chocolate is going to win. Chocolate is going to win.
You know, if I could comment on the question, right? Of course, I agree with everything that's been said so far. To me, this is a story, like so many other things, about a desire that we have as providers to do something, right? We always want to do something, whether the something is withholding fluids to keep someone a little dry so that their lungs don't fill up, or whether the something is pushing IV fluids because they have a fever. And the problem here is that the more we do something without good evidence behind it, the more we have a risk of doing harm. And so I agree completely. The answer here is probably, until we know more, it's euvolemia, it's attention to volume depletion. It's probably not, and I'm sure, or if you didn't mean this, probably not pushing fluids hard, because these are our frail elderly patients. They were frail and elderly before the pandemic. They're not going to be able to tolerate a whole lot of extra fluid. We have to be careful about that. But we likely don't want them to wither too much of volume depletion either.
Yeah, but I would, I mean, having said that, and having said that, I would say that, I talk to my practitioner teams at the front line, and I've seen a few patients myself. Man, volume depletion is a concern. I mean, again, loss of taste, loss of appetite, loss of function. I think that kind of all adds up to the same story. So I think we have to be very, very, open-eyed about it. And, IV hydration has a role to play. Cautious IV hydration has a role to play. And it also kind of points out to another important thing, that we can't get away with our COVID patients who are mildly to moderately sick by just seeing them once a week. I think this just gets to some philosophy and conversation we've always been having, like, what is the role of the medical team, medical provider, is that, we need to be more present. I mean, this is not just one and done. You diagnose somebody with a COPD exacerbation, put them on Zithromax and steroids, and then after a week later, see ya, and then the nurse will call me. No, these are the people, we really have to eyeball them as much as possible, which, by the way, gets me to a topic which is not a topic tonight, but it's a very important topic, is what is the role of telehealth and how distant the team can be. And to me, with hydration status and assessment of those things, it's very hard to do a good job when you're away. So I just want to highlight that quickly, that there's pros and cons of technology here also, which we need to keep in mind.
Hey, you did not go to my webinar yesterday on telehealth, apparently. It was a great webinar, and I think the whole telehealth issue is one of the fascinating, unexpected turns here, and that can work so much in favor for our patients coming in the future. So yes, telehealth is definitely has a big role, but somebody is saying, boo to telehealth and COVID, my team sees the patients every day. Okay, you know what? Let's have a discussion about, let's keep that thought and discuss that maybe next week some more. So I think that hydration is a very important topic. And so from what I have seen is that, and there's is somebody here is the FTT, the failure to thrive, the listlessness, if they are actually symptomatic, that is a pretty big concern. And I've seen some fairly rapid turnaround of that. And then if they don't go, and many of my patients have not gone on to cytokine storm. They actually have done pretty well. And I think we are all seeing it. If they do poorly, however, it all goes to hell in a handbasket very, very quickly. But a little bit of hydration, I think, is not going to harm them. And you can always consider crisis in this situation if you are concerned about too rapid volume overload. Crisis is something I think that's getting more and more popular in our setting. In Germany, we've been doing this for a long, long time. Actually, I think here probably in this country as well. So moving on, let's see here what our audience says. Larissa Lucas says, my theory on the failure to thrive is that they lose their sense of taste, smell, but can't explain because of dementia. Thoughts, any ways to test this? Sprinkle pepper on their tongue, and then she's going into the boo on telehealth. So we're going to defer that one. But does it make sense to do any kind of testing on this? I mean, I guess those people then would be at higher risk if they've lost their sense of taste and smell, which many of them do apparently. Any thoughts on that one? It's a little bit out there, but hey,
No,
let's
my
discuss.
poor man's test for that is ice cream. Still,
Oh,
sweet tends to be the last sense to go. There's some articles that you lose your sense of sweet tasting, but in general, when they won't take something sweet, I'm concerned about failure to thrive and intonation. Smell, you know, a noxious substance, but some of them are so used to noxious substances, I don't know if they respond or not.
I think we're coming back to ice cream. I think that's one of the big takeaways, ice cream.
We're serving root beer floats. It's amazing how they'll drink it.
Yeah, I think a intervention that probably won't harm is ice cream. Okay, good. I think now that we've covered that, any other comments on this?
Oh, yeah. I think we should, talk a little bit more about diagnostic testing. I'm not talking about the viral testing at this point. I'm talking about diagnostic testing because I think somehow we kind of missed that piece in the anticoagulation conversation also, because D-dimer or no D-dimer, where are you guys standing on that one? So I would love to hear from Chuck and Rich. Are you in the party where you want to do D-dimers before you treat, or are you just like, no, D-dimers don't add much value? So any comments on that? And I can share my opinions too later on.
Yeah,
and then always the science behind it or the lack of.
Yeah, I personally don't order them probably as much as I should. I don't know how much they help me as opposed to clinical acumen. I'm one of those that's at the bedside, and I think I can tell how sick a person is by vital signs and other measures and standard blood tests. I'll grab an occasional CRP. But I think the whole battery of tests tends to be more of a hospital setting issue than a nurse home setting. And I think it does depend if it's somebody de novo in the home versus a recovering COVID patient. A recovering COVID patient, I don't bother with them.
So I'd say, sorry, you know, in our provider group, we have not adopted any kind of an order set so that everyone gets the same labs or anybody gets the same approach for the same reason, exactly as you described. This is an individualized decision. Certainly, I'm sure some of our teams are ordering D-dimers to guide therapy, but in the absence of data, we didn't want to make a formal recommendation about that. Ultimately, one could very readily decide to use prophylaxis without a D-dimer, and we're not sure what having it's going to do. So we're very reluctant to set policy for very large numbers of patients without having evidence behind it.
Yeah, no, I agree. I mean, there's a lot of studies from the hospital side that if you have, 3 times increase in D-dimer, then, they're going to be high risk for a poor outcome. And there are some studies which have been released which show mortality correlation. But again, those are the patients which probably should be in the hospital and not in your facility. So we're not at Signature, if I'm getting a question around it, I'm not recommending it, but I'm not also putting a big no to it or calling the physician like, why did you order a D-dimer? I mean, this is what helps you in making your decision a little bit better. But I mean, what I would have problem with was when somebody was just using a D-dimer by itself to make a decision without examining the patient or getting more clinical history. I mean, unfortunately, sometimes I've seen that happen in our setting where a doctor will respond to the nurse's one question, like nurse will like say, for example, hey, Mr. Smith is getting a little bit short of breath. What do you want me to do? Order a D-dimer. Okay, what next? Just call me back with the result. And the nurse calls back the next day with the result and like, oh, D-dimer is like 3 times higher than normal. Like, yeah, start them on a, so that is something which I would probably not recommend at all. But I mean, as long as these tests are being done on an individualized basis, just to help you in your clinical decision making. I mean, a good case example for me who probably we should absolutely think about anticoagulation, think about it, not definitely put them on it, would be somebody who used to be mobile, used to be up and about. Now, because of COVID, they've suddenly become bedridden and they're not doing any activity. And now they're also dropping their oxygenation, right? I mean, that is a classic patient to me where I would absolutely, think about anticoagulation and probably put them on at least prophylaxis anticoagulation. But again, D-dimer, I'm not really sure if that's going to add too much to my decision making at this point. And the reason I wanted to bring up testing, not just in the context of anticoagulation, but also diagnostic testing, really because we have seen that some labs have refused to do these testing, right? I mean, because there's a concern that are we going to spread the disease by ordering too many testing? So I think we have a responsibility here from that point of view, as Rich mentioned before, from staffing partnership, that we want to make sure that we don't put our staff to just undo necessarily harm, because testing is a pretty intimate activity. You're going to have somebody going pretty close and break that infection barrier. So let's make sure as clinicians we're not ordering tests which are not bringing much value, but are putting our colleagues, other healthcare disciplines at some risk.
Yeah, my from a primary care clinician is I don't want to order tests if they don't make a difference in my decision making, and I think so. I have not ordered D-dimers and LDHs. I mean, I've ordered them, but not specifically. I wouldn't even know what to do with an elevated LDH other than, okay, we'll continue to either observe and see whether they're getting better and or not, And I apologize about my dog. All right.
Can I just one more? I just want to make one more comment, and again, I'm just trying to learn from these colleagues I've had at my disposal right now, all three of you. So I think the LDH issue is an important one, and I think it has been highlighted significantly by this JAMA study, where this Chinese researchers did a great job of putting a framework around creating risk factors for people who would not do well with COVID and who will kind of deteriorate. So what they did was they found that LDH, bilirubin levels, X-ray abnormalities, coma, and there's 3 or 4 other factors. Yeah, and then they gave you a website. Actually, all of you can go to a website, put those things in, and kind of see what is the risk of, what's the chance of your patient declining. So I think there is some value to some of those things, but again, from the nursing home side, I just do not find that we can use any of that at this point. But I'm starting to get questions based on that study, like, hey, should we be ordering a liver profile and LDH and so forth? So I think these are fascinating areas which are not ready for prime time in our setting.
But if I could build upon that, the area where they may become applicable, and again, we don't know exactly how to use them, is if we're trying to prognosticate for a reason, because it's going to change what we do next to the point that was just made. So let's say someone is not do not hospitalize, someone who we might hospitalize if we thought they were declining. And of course, we're all looking for hypoxia, but let's say that they don't have hypoxia and they're looking okay, but we're still just not sure. I might utilize tests like this. I might look at an LDH as an example, as one of the things, one of the markers of a higher risk, and that might be someone who I might err on the side of sending to the hospital sooner rather than later, if it's someone who's truly a candidate for hospitalization, maybe even ventilation. But so many of our patients aren't. And in those cases, if we're not going to send them to the hospital anyway, I just don't see how it's going to help us in managing them on site.
Mm-hmm.
Again, back to the Sabine's gold standard question there, is the test going to make me do something different, right? I mean, if it's not, then it's just an activity in futility at this point.
Mm-hmm. Yeah. And I'm on Chuck's side, more like do intensive monitoring, and I have had monitoring more for the hypoxia. Early on in March, we started every 2 hours, which brings us to, I think it's Bob. Bob I think you are a vendor with Vital Connect. So there's something here that I have looked into but have not really pursued. There is a whole suite of monitoring devices have come up. Wonder whether any of you have used them. So there is the oximeter probe. That is just Massimo makes it, I think. It's just a finger probe. It's a strip. And you can have a dashboard out up front. There are other, more distant devices, other devices that monitor vital signs. That actually, Arif is probably right up your alley. There's a lot of innovation going on right now, also for the home and assisted living space. Has any of you taken advantage of what's out there yet to keep a really close eye on our newly diagnosed COVID patients?
So I think I shared that with one of your Washington webinars, Sabine, that we have piloted remote patient monitoring using the Bluetooth capability to transmit the vitals to our practitioner team. And unfortunately, we found out that the apparatus we used were just not very staff friendly. So we kind of looking for a newer apparatus on that. because the battery life was just short, and that was just creating too much churn for the staff to make sure that they could charge it again and again. So,
Okay.
as we do these vitals, we will find out the strengths and weaknesses, but, we can't get away. In the future of infection control, where we have to be hands-off as much as possible, we just can't get away without working with some remote patient monitoring devices with Bluetooth capabilities and all of that. We have to go there. So I think more and more companies are jumping into it, and AMDA, I think, it needs to play a very important role in making sure that how we can make some of these technologies be successful faster, so that we can provide those capabilities quicker at the front line.
Yeah, well, thank you for taking the lead on us, on that for all of us. And I think we're going to move into our last topic that we were planning right now, and that is testing. And in particular, I think we had looked at antibody testing. So why don't we go ahead with question number 6. So audience, you can now participate. It's a great question. I didn't write it. I think we're close to having the poll done. Let's see here, with just a few more minutes. There's some innovative stuff going on here, as I can see on the chat. So I think we can end the polling. All right, so the majority are looking at antibody, we're not talking PCR, no, antibody testing to determine the status of a building. And some of them do the status of the individual or justice staff. This is a very interesting answer. I have some fairly strong feelings about that, but I'd like to know, were any of you would like to go with that? Do we think antibodies are ready for prime time? And again, what we talked about earlier, will they make a difference in what, will they have consequences for us as clinicians or as medical directors too? What's your take? Rich, why don't you start out this time?
Yeah, I know several of us have some strong feelings about this. I think the story about antibodies for COVID is a story about what we think we know. Not what we know, but what we think we know, right? We think we know that IgM converts when people are acutely infected and IgG comes thereafter. We think we know that IgG then is specific to the COVID, the coronavirus, the novel coronavirus that we're dealing with now, SARS-CoV-2. We think we know that the presence of IgG against SARS-CoV-2 is protective against reinfection, but we don't actually know any of those things. That's the problem, okay? So as I'm sure that everyone on this webinar has been reading and has been learning, there's a significant issue with false positive rates with the antibody test. There's cross-reactivity with other coronaviruses, and we do not know whether the presence of IgG against actually the right virus, SARS-CoV-2, we do not know if that is protective against reinfection. We think we know, because that's the way a lot of other things operate in our world. We think we know, but we don't. But because we don't know that, that's why leading infection control authorities and officials and infectious disease experts with far more depth of knowledge than I have, that's why they have all said, do not use this for patient-level decision-making, whether it's around making a diagnosis or discontinuing precautions as though you're immune, you've got your immunity card. They've said, don't do that, that's dangerous. It may turn out that sometime down the road, weeks, months, I don't know, we'll know more about the answer to that question. And at that point, it may be that the presence of IgG, we will actually believe, we will know to be protective, and it will have more utility. But at this point, it's actually dangerous. It's actually dangerous to use it in ways that are not evidence-based. That doesn't mean, though, that there's no use. There are few limited use cases that maybe we can come back to, because I've been talking for a while. There are a few use cases, but it's not universal. So I'll turn it over to others to comment.
Yeah, so I think you have strong feelings, and I'm going to keep my feelings in check here on that one. I want to know from the other panelists, are you using these antibody, they're really well marketed too, and they're quite pricey. And some of us may have been seduced, some of our CEOs may have been seduced to buy them because we couldn't get PCR. That is actually what happened in our company. We were hoping to use anything, and to the tune of quite a bit of money. So my question to you is, are you using those antibody tests? And if so, what for? Chuck?
Yeah, we've held a hard line at WashU. Just as Rich said, there's too little knowledge. We need studies first. We're not going to do it. Having said that, there's been individual times I would have loved to have done it. You can always come up with a scenario in which even partial knowledge might be helpful, but it still is best done in experimental trials in large community settings to determine the health of a building or a population.
Mm-hmm.
I think that's the setting that's going to be used in. And as more states now are going to be geared in to do mass testing of their nursing homes and end up with staff with positive PCRs, and then what do you do with them? They never had symptoms. Are they still active? You're going to furlough them for 10 days and cause a more shortage crisis? It's very tempting to test those people, because then the hope would be, well, you had the disease, you don't have it now, but the data is just not there to do that.
Mm-hmm.
But, I would love, we got marketed right and left.
Yeah, man.
The sensitivity is horrible. IgM don't touch. That's
exactly.
really bad.
Yeah, that's pretty much it. IgM, don't even worry about it, because it's so non-specific, and then the IgG is also not great. So RF, close us out on that one. Can you try?
Yeah, no, it's a very important topic, and I think I will focus on what we do know about it, right? And we can always use that and start from there to building our own story. I think, unfortunately, the story for the antibody testing has been written for us by the media, by the terrible startups who just want to make cheap money, and then and that has created a lot of questions and emotions around it. I just want to come back to what we as physicians and scientists know about it. That is a very important part of the story, which will play a huge role eventually. Not right now. Eventually, it's going to play a huge role in really understanding this problem. I always kind of use this example, like, PCR is always going to be, we know that we cannot use the antibody test to diagnose anybody. So that needs to be absolutely clarified. The only way to find somebody's infected is always going to be PCR. You will never make PPE decision based on a serological test. We know those two things. But, again, serology will have a very important role to play in the story as we learn more about it, right? So I think for us to kind of shut it off totally because of an emotional response, which a lot of us have felt around it, I think is not the right thing. And anybody has said that on this panel. I'm just talking about in general. So I think we as AMDA and we as healthcare leaders have to make sure we write the right story around it. So at Signature Healthcare, we actually are creating a comprehensive program where we will be doing one step ahead, and we will be doing serological testing on a lot of those patients where like Chuck want to see exactly what's going on, and we just don't have the capability. So we're working on a program where buildings will have the most credible test available to be able to do that, so we can start learning from it. So we're actually working with national experts on creating an evaluation program around it. So we're not going to just wait for this literature to come, because it's not going to come. We're going to keep on struggling 6 months later too. So I think we have an opportunity here to kind of write the story ourselves, take things in our control, and that's what will be my goal that AMDA does also. But I agree, at this point, let's stay away from it, from making decisions on day-to-day patient care, because that way we could get in trouble. We can still use it to understand, your staff exposure to it to some level. You can still understand building exposure at a broader level, but you should not be using it at all at an individual patient level at this point.
So I want to let somebody in the audience have a comment here, and I also want to. You all have seen the chat from Larissa Lucas that there's a pilot testing via MIT Broad Institute collecting antibiotic samples. So there is, I think, we certainly want to support that kind of research. Irene, what do you have to say?
So I listened to Christian Drosten in Germany. He's the premier corona researcher of the world. And he says that there is likely very robust immunity with neutralizing antibodies being built. And that's what was just also proven. And I'll have that in my update tonight with macaque monkeys. And also from the SARS-1 epidemic, where the SARS-2 came from, because the correlation with the RNA is 79%. So it's very like SARS-1. Germany has developed a serology test that is 100% sensitive and 99% specific. It's very different from the US produced serology tests that are in the 94 to 96% range. So if you test in the US with the serology test, yes, you'll get a 44% chance of a false positive. If you use one of those German tests, it would be 17% false positive with a population prevalence of 5% in the population. So as the numbers go up, it'll increase. So the way I would approach it is if a patient or a family member or a staff member says, I had all the symptoms of COVID, I had it before there was testing available, I didn't get tested, but I'd like to have the antibody test, I think the pretest probability would be pretty high. Also, if somebody is not exposed to a lot of other coronaviruses, that could possibly cross-react. So the German test is very specific to COVID-2, but early in the disease process, the IgM antibodies are quite sticky and can cross-react with other coronaviruses that people get from their grandkids, their kids, from just a cold. The IgG is very specific to COVID-2 and would not cross-react. So if the disease process has been longer than a couple of months, then it's going to be IgG that's going to react, and it's going to be a pretty reliable test. Okay. So I would not throw away the serology too far because it's coming. It's just our tests stink right now. And I think the FDA has just been pushed into the corner to approve things, to make things happen. And they were not funded adequately to do the testing that should have happened.
Okay, well, thank you. So there's more to come. I think that's the consensus. We will probably have better technology. Yeah, it's coming out of Germany. What can I say? You know, you know, they've been working on this test since January. They had promised it in March, but yes, because it was shitty like the ones we have, they put it off until, and it was just approved 2 weeks ago. So they really did a good job with it, and we're not in a hurry. Okay, good. Is there anything else that anybody would like to bring up? We are closing down on our time. I had one question that was put to us, and I thought it was an interesting question that has come up for me recently too. It's not really touching on the topics we are talking today, but somebody was asked, well, when can we start nebulizer treatments again on COVID patients? And I'm like, whoa. But I'd like to hear what your take on that is. And I think there's different aspects. Is it for a COVID patient, or is it for a patient in a facility that has COVID patients or COVID neutral? What's your take?
I'd love to jump in.
You raised your hand.
I have energy around this, yes. So, well, how are they doing? I mean, if they're not using their albuterol nebulizer and they're doing okay, then why do you need to restart it? Maybe they never needed it in the first place. That's the first order of business, is questioning whether we were overusing these things. And just to throw it back in, that contributes to polypharmacy, an increase in nursing burden, and all these things that we don't need to be recreating right now. On the other hand, if they do clinically need it, well, then maybe they should be having it now with airborne precautions. So I think it's more about patient need than it is timing around the COVID, but I'll turn it over to others to comment.
Great answer in my book. I can tell you that we had one patient, and that's one patient. And how many people had nebulizers before? All the time, right? One patient who actually appeared to need it, and we have put that patient in a separate room in 95. I mean, we put a lot of safety guards around this particular patient who was not actively COVID positive. But it is amazing how much we are doing, how well we're doing without all these nebulizers, isn't it?
We discontinued tons and tons of nebulizers, and we had 2 cases where we had to send 2 people to the hospital out of all of them because they really needed it. So there's going to be a few who really, really need it, and I'm stuck there. I mean, I just do not want to start a nebulizer because the risk is just too high. So I don't know, Chuck, what your comment would be for those 2 people who really needed it. Unfortunately, I felt so bad that they had to go to the hospital because of that reason.
Oh, we kept that person in the facility, but that was the facility that has been written up in the New England Journal and all of that. They're beyond that outbreak now. They're well on their way. In an active case, I would not have kept that patient in the hospital.
Yeah, my comments echo Rich's in terms of, first of all, we were overusing it and didn't realize it.
Mm-hmm.
I personally have been suited. You cannot start nebulized treatments without first trying MDI with spacer. I don't care how bad a COVID they look. And frankly, if they start failing that, I'm not convinced they wouldn't have failed anyway. I don't think a nebulizer is going to save anybody from going to the hospital. And for the few that do, it's probably worth not risking the facility. Right?
Mm-hmm.
The risk of nebulization is too great for nursing home.
Mm-hmm.
We can get negative pressure, so.
Okay.
So there's no future of nebulizers in post-COVID era then?
I will find some.
I think I wouldn't buy stock in nebulizers.
Yeah, I would put them in the cruise industry bucket then.
All right. So I think we're ready to wrap up. Unless there's any, do you want to say? Is there anything else you would like to say in closing, or anything beyond what I'm gonna just quickly close here? I don't see any more questions or comments from the audience. So I'd like to close with a sentence that I read in the Washington Post from May 7 in an article titled "Amid Darkness, They Work to Light a Path." And the sentence is, armed with information and reassured by a compassionate expert, most people are willing to take a chance. And that is sort of, I think, is a very powerful sentence, and that's what I want to be. I think that's what we all want to be. We want to have information, look at the information critically, and then become compassionate experts for our patients. And I think, and for our staff. And that's sort of basically why we're putting on this webinar, so that we, in this space, I mean, there are other diseases, but in this disease now, for our space, that's the goal of why we're doing this. And I want to thank you all for participating in this lively discussion. And I have learned much, and I think we have learned much. Just a few things that I learned was, as far as anticoagulations, always think about it. Definitely something for patients in the hospital. When they come back, definitely indicated duration, probably at least 3 weeks, possibly longer. Hydration, well, again, always think about it, but I don't want to repeat that. It's like, really pay attention to volume depletion in our patients. I think that's what this is all about. And we know that volume depletion, we have very high risk for volume depletion from the circumstances of the nursing staffing in the space, and also the disease itself, or the loss of taste and smell. And I think the real pearl that we got here is like ice cream. We can never go wrong with ice cream in this setting. And we don't know whether it's vanilla or chocolate, but probably my bet is on vanilla. And then as far as testing and via antibodies, we're not ready to make, this is not ready for us as decision makers. However, you know, that is today. And in a month, this may be all different. So a very special thank you to all for sharing your expertise with us today and taking the time in your, I'm sure, very packed schedule. AMDA will continue with the COVID Grand Rounds as peer-to-peer discussion, bringing you topics of greatest interest and up-to-date information. And not only that, really how this information specifically relates to the care of our patients during the COVID pandemic. If you have a suggestion for a topic you'd like us to cover, please email us. Erin will be happy to take those emails. And we will see you the same time and same place next week. Be well, do good work. Thank you very much. Bye-bye.
Thank you.
Bye.
Thank you. Bye. Bye, everyone. Thank you.